Okay, we're going to discuss some of the assessment things that we're going to be talking about in neuro, and then we'll go into talking about the different types of seizures. So, just kind of looking at a rapid neurological assessment, if we're looking at an unconscious patient, the main thing that we're going to be looking at is their level of consciousness. Have they had behavioral changes? Are they able to think through things? Are they responding appropriately to whatever you ask them to do? So if we perform this very accurately and succinctly, we'll be able to get a good idea of how the patient is doing. Should take about less than 4 minutes to really get a good assessment. So we're looking at their behavior, and have there been changes? Are they having outbursts, like tantrums, or are they depressed? Are they doing some risky type behaviors? Are they denying that they're having any kind of disability or anything? And then we'll also be looking at physical changes, such as their pupil size, the shape of the pupils, and how they react to light or don't react. Any change in any areas of the brain that are affected are going to kind of be shown in many of these ways. Ovoid pupils, where they're larger and more of an oval type shape. It's kind of a ominous sign that there's some kind of problem going on, that there's an increase in intracranial pressure. Fixed, dilated pupils are a very bad sign, and often you'll hear people refer to that as blown. So they'll say, their pupils are blown, or their right pupil's blown, whatever. So that's a bad sign. It's a real indication that there's a traumatic event going on. If the patient's conscious, we'll also be checking their gross vision, the extraocular movements. You remember those cardinal ranges of gaze and what have you. So if the patient's able, we'll be doing those kind of things with them. If they're not, obviously we won't be doing them. So we're going to be looking at motor and sensory perceptions and abilities. Are they able to use their limbs? Are they not able to? Is the strength better in one side or the other? So we'll be looking at motor loss and their function or dysfunction. And often these dysfunctions will occur on the opposite side of the lesion on their brain. So, which I know Ms. Briscoe's talked to you about that, so I'm sure you're already well aware of that. What kind of posturing are they doing in their body? What type of movements are going on? Are they having trouble moving? Any decreased or increased muscle tone, any weakness, that sort of thing. The sensory side of it, of course, is can they feel us touching their feet or their hands or their arms or what have you? And do they respond appropriately to it? And also, can they speak? Can they communicate? Are they able to swallow? So those kind of the lines of whether that's motor and sensory sort of blur a little bit. Okay, so some of the things we'll talk about later on are going to be traumatic brain injury, intracranial pressure, and herniated syndromes, coma, vegetative state, tumors, infections, and seizures. We'll move right on. That's what I've been talking about. I just didn't let you in on it. Okay. That's on the conscious patient we were talking about, because we'll be asking them to perform some things and see if they're able to follow commands and do these tasks that we ask. Now, on an unconscious patient, well, that's a little bit different, isn't it? So, on the unconscious, we're going to also check their level of consciousness. We're going to look and see if their pupils are reactive, and how reactive or sluggish, or the shape, or what have you. And again, we're going to be trying to do this on the patient. Something you may have read about and practiced, if you've already been to the neuro unit, I know you have, or if you work in ER, is a Glasgow Coma Scale. And this is only used for a level of consciousness. It is not a total neuro assessment by any stretch of the imagination. It looks at 3 basic things of our clients: eye-opening, verbal responses and their motor response. And what I mean by that is that we go in, and I think I have one here in a second to show you. You may have to look in your book and see, but here we go. Here's the category: opens eyes, verbal response, and best motor response. And you select which the patient is able to do. And you see the scores over here in each section: 1 to 4 on the eye opening, 1 to 5 on the verbal response, and 1 to 6 on the best motor response. And so the highest you can make is a 15. And you'll see the lowest we can make is a 3. And anything much less than a 7 is not a good thing. So not good at all, and you'll see how we're talking about that. So this is a real quick assessment that is kind of a standardized assessment tool of how alert a patient is, their level of consciousness. So number 1, in the eye opening, they don't get any if there's no opening of their eyes with any kind of stimulation. Now you see, but we still give them a 1 because they're breathing, okay? And then to pain, they open it to noxious stimuli, and that noxious stimuli can be like a sternal rub, where you ball up your fist and use your knuckles to kind of rub on their sternum pretty briskly, and it's pretty intense if you're awake and alert. There's also a trapezius. You can squeeze the muscles of the trapezius. You can put gentle pressure on their eyeballs. Be real careful doing that. Some people will do on their finger, nail, put pressure, like with a pencil underneath it, and put pressure on the top. That's pretty painful. You will see people pinch in the inner aspect of the thigh. You'll see, unfortunately, you'll see a lot of different things, but nipples are quite sensitive, and that'll be a place that sometimes they will pinch to get response from patients. So if there's no response to any of these stimuli, to nothing, we give them a 1. If they do open their eyes to a noxious stimuli, we give a 2. If we go in and we say, Mr. Smith, and they open their eyes, we give them a 3. If it's just spontaneous, we're not, it's not to verbal or anything, they just know we're in there or whatever, and they open their eyes or kind of look around or what have you, we give them a 4. On the verbal response, we check to see if they don't answer us, not even to noxious stimuli, and say, oh, or stop, or what have you, then we'll give them a 1. If they moan or groan, we give them a 2. If they fuss or to say something inappropriate or disorganized, whatever, we give them a 3. If they're confused, but their answers are inappropriate or whatever, but they use language correctly, we're going to give them a 4. If they're alert and oriented to person, place, time, and personal data, they get the 5. So you can see how it starts adding up. The more alert you are. The best motor response. We're going from there's no response to noxious stimuli, they're flaccid. That gets a 1 point. To if they've got abnormal extension, to spontaneously, or to noxious stimuli. And again, abnormal flexion, we'll talk about those in just a minute. Or if they withdraw from pain, that's a good thing. If they can withdraw, if they can move their arm, or they try to move across the midline of their body, trying to push you away from whatever you're doing to them, that's a good thing. We call that localizing. That's a 4, or that's a 5 actually. And then obeys commands. They can do simple tasks, whatever you ask them. Hey, they get a 6. So you can see that's the basis for our little thing there. Get back to this. Okay, I think that was all we're looking at. Okay. Okay. So some of the tests that we're going to see. I wanted to say one more thing. with what we can kind of expect. Now we all know how that is. It depends. But with some different kinds of brain injuries, we can, if we hear someone say, well, they had a mild head injury, on the Glasgow's coma scale, they might make like a 13 to a 15, which is rather high, 15 being the most you can make. They may have had a loss of consciousness for up to like 15 minutes, and then they're back, and everything looks good. They're able to do most of the stuff you ask them. For a moderate head injury, they may have scored between 9 and 12, so you can see that score coming way on down. They may have lost consciousness for several hours, maybe even 6 hours after they had their head injury. They might have to stay in the hospital, in the ICU for maybe overnight. But they don't have any other systemic injuries. They're just going to watch them. And then a severe head injury, they may score 3 to 8. And remember, 3 is the lowest you can make. It's no response to anything. And with that, you can expect that they've probably had a loss of consciousness for several hours, like greater than 6 hours, and they're having ongoing management of physiological parameters and what have you. So obviously they have not as good a prognosis either. Okay. Some of the other tests that we might do for these clients, and I'm sure you've either had some of these at some time or had family or had patients that have. So these are some of the diagnostic tools. Hey, you already know all of these. You've been doing them for all sorts of other things. The CT, MRI, cerebral angiogram, myelogram, cerebral blood flow, electrophysiology studies, and LP, all of these. So, but we do want to remember that a patient that is on glucophage for diabetes, remember metformin, if given the contrast, I'm not saying they won't do it, because they may feel that the patient getting a CT with contrast is more beneficial to the patient, and we'll just watch them and make sure we don't let their kidneys fail and get it flushed out and what have you. But we want to at least be aware of that and call it to someone's attention. Okay. All right. So, here we go. So we're going to look a little more at some of the other things. We want to know what's going on with... Oh, got too far ahead. Hold on. Want to know what's going on with the patient, what kind of history, and they may not be able to tell us at that point, but maybe there's some family or someone that witnessed whatever is going on. So the patient may not be able to tell us everything, but we're going to try to glean as much information as we can. And sometimes these patients are not good historians either, but we want to see what's going on. What were they capable of prior to the injury? So what is new, what's worse, that kind of thing. We're always trying to think of those things, okay? So we're looking at, not only at the neuro, we'll look at the other situations that are going on. Did they have other injuries? Do they have other comorbidities going on? So those are always very important. Okay, we're going to bump on into seizures. And I'm sure you all know what seizures are. Where they have abnormal, sudden, excessive, uncontrollable discharges of neurons within the brain, and it causes the patient to have very spasmodic kind of episodes. And these can be single episodes, or they can be off and on, intermittent. They can be lifelong challenges that the patients have to deal with. Epilepsy is where patients have a chronic, recurrent kind of episodes of these, and there's the type that have no brain lesion, which are called primary, and then the secondary where there's some other lesion or they've had a trauma or something that has caused them to have seizures. And I think about 2 million people, which is about maybe 1% of our population, have seizures, and 80% of them are able to control their seizures through medications and such, so that's a good thing. Some of the other reasons that patients can have seizures, though, that are not epilepsy in particular, are metabolic problems that can go on, like with their diabetes or blood sugar get low, that kind of thing. Acute alcohol withdrawal. Electrolyte imbalances. We're always talking about hyperkalemia or hypoglycemia. Those things all it can do it. And also heart disease. Now, there's several types of seizures, and we're just going to talk real generalized about some things. Generalized ones, in fact, are where both hemispheres, both sides of the brain are affected. In the partial seizures, only one hemisphere is involved. So, and we see here with the generalized that we have several different types. We have absence, what sometimes is called petit mal, atonic, tonic-clonic, tonic-clonic, and myoclonic. And then on the partial, we have simple and complex, and then there's some that are idiopathic. And guess what? Unclassified, over probably half of the seizures are unclassified. We don't really know what the reason is. Okay? So looking at the generalized, and when I'm saying an aura, that is just like a sometimes people feel a deja vu or a strange tingling or a taste or a smell or something visual, and they know they're fixing to have a seizure, and which is a great thing. Not everybody has that, but and then they'll have a sudden. This is the tonic-clonic. So this is what also has been known as the grand mal. They have this aura, then they'll have a sudden, immediate loss of consciousness, and they'll get stiff. That's the tonic phase. And then they'll go into the rhythmic, jerky kind of stage. That's the clonic phase. And then after this, and it's usually just lasts for a minute or 30 seconds to a minute, generally. Sometimes up to like 5 minutes. But you can imagine that's a really stressful thing on your body, because during the tonic phase, your body gets real rigid, and they may even cry out or moan or what have you. Their respirations stop, and the patient can become cyanotic. So, we're going to try to get oxygen to them as best we can. Their jaws are usually fixed, and their hands are usually clenched. So, they're not going to be breathing. This is where they say, don't try to put something in their mouth. In the olden days, we used to say, try to get a tongue blade in there or an airway or something. Well, now they say don't. That causes too much injury. You can get hurt, and the patient can get hurt as well. So we don't do that. Then they go out of the tonic, which usually lasts about maybe a minute without oxygen, remember. Then into the clonic, which is the rhythmic, jerky kind of contraction and relaxation of all the muscles. And the patient is usually incontinent, so that's one way you can always ask. Well, they'll say, I had a seizure. Well, were you incontinent? Well, no, I didn't soil myself or wet or anything. So, that they may not have had a grand mal or tonic-clonic. They may bite their lips or their tongue or the inside of their mouth, and they may even have some frothing, just like saliva that's kind of blowing out. And that'll last for a little bit. And of course, the tonic-clonic phase, all totally should last about at the most 5 minutes. And then the patient will go into what we call the post-icteral phase, and that's where they're exhausted, as you can well imagine. Fatigue, lethargy, confusion, and they may be just very kind of stuporous and hard to wake up. And they need the sleep after that. But we want to watch them, maybe put them on their side. So what are we going to do for these clients while they are having all this? We want to try to protect them. We do not want to hold down their limbs, try to restrain them or anything. We can put some padding around them to keep them from hitting the side rails if they don't have pads on the bed, which are more of a taboo anymore. Used to we would do that, but if someone's having seizures pretty frequently, I'd still do it. I just think it's just a better idea, personally. But anyway, we want to, if they're on the floor, we want to move furniture and, maybe try to put a pillow up under their head so that their head's elevated, but, we're not going to try to hold their limbs down, that sort of thing. Not going to try to put a tongue depressor or anything in their mouth. and give them oxygen as soon as we can by a mask or something. So some of the tests that we'll do on these patients are EEGs and CTs, MRIs, that kind of thing, because we're going to want to rule out any brain lesions, okay? And remember, if your patient's ordered for an EEG, we want to hold the caffeine, hold any sedatives, and also some of their anti-epileptic meds might be held, but we want to make sure and ask, because we don't want to cause anyone to have seizures, but very often they don't want us to give certain meds, so we'll have to ask which ones, and they'll usually tell you what they want held, but we want to ask if we don't know. Okay. There's a chart, 44-5, best practice during seizures. You might want to check at that. Now, some of the other seizures, like the petit mal, also known as an absence, atonic, tonic, clonic, and myoclonic, which we kind of went over those. Absence is where they'll have like a blank stare, like they go kind of out into la-la land. It affects children a little more than adults, and you can imagine children are in school and they're sitting there and they are probably more prone to daydreaming anyway, maybe not than some of us, but often. So it can interfere with their schoolwork, and certainly for adults it can interfere with work. So they have a sudden, brief, very brief loss of consciousness, and they stop doing whatever kind of motor activity that might be going on, but they'll just kind of stop and do a little stare, and that's petit mal. And, of course, the atonic, that's sudden loss of muscle tone, and they can get injured because they fall, and then they'll also have a postictal. And the tonic seizures we talked about, and the clonic, we talked about the tonic a second ago, the muscle tone and getting rigid, contracting. And the clonic was the rhythmic contractions and relaxation. And myoclonic, sudden jerking of a single group, myo meaning muscle, of a single muscle group. And it usually lasts just a few seconds. And a simple partial, we talked about partial being just from one hemisphere. Sometimes they'll have that sensory phenomenon kind of thing. They may do automatic things like pill rolling or finger twitching or scratching or that kind of thing. Let's see. Mostly these affect adults, though. And unfortunately, these partials are less respectful of medicine and treatment, so they're not as reactive to it. But they don't lose consciousness either. And let's see, sometimes, when I was saying the myoclonic, and it starts with a jerky movement, either a single group, and then it may move on up. That's called a Jacksonian march. It's like maybe their finger starts twitching, and then before you know it, their hand and their whole arm is just twitching. So, and sometimes they may have a change in their posture, or they may kind of utter a little words or a little bit of spoken word a little bit. Was a simple partial, and then the complex partial, the patient will black out. And in my book, that's a little more serious anytime you look at it. You lose consciousness. And they may do some of those automatisms, either smacking, chewing, that kind of patting or picking at their clothes or something, sort of like they're in a kind of dreamy sort of state. And they may also, sometimes they'll kind of act out, and show some inappropriate behavior, which may lead some people to think maybe they're getting a little psychotic. So, and these can evolve into generalized seizures. Okay. This is the only kind of partial seizure that they lose consciousness. Okay. We're moving along rather rapidly. These are some of the anti-epileptic meds, and you'll notice, oh my goodness, there's some you already know. So I don't think you have to do a lot of scratching and looking around, because you kind of have an idea about these. Tegretol, Klonopin, Depkine, Neurontin, Lamictal, Luminol, Dilantin, Topamax, Depakote, and Depacon. So, I mean, these are all meds you're already a little familiar with and have given, and you know that some of them you have to really watch for toxicities, and you'll see that we're starting to see meds that we'll use for anxiety, meds we'll use for seizures, meds we'll use for neuropathies. So, I mean, you know, hey, we use a lot of things for a lot of different stuff, but those are your anti-epileptics. One, I'll point these out because, you know, we'll see them used a lot. And that's going to be the Valium, Ativan, and Dilantin. And the Dilantin, that therapeutic level is just for the Dilantin. It's certainly not for the other two. Therapeutic level is 10 to 20 micrograms, and see what some of the side effects are. One thing I do want to mention, I mean, you can read over that, but absolutely, Dilantin is only given IV and PO. So, in IV, it is not mixed with anything other than saline. I repeat, Dilantin. You cannot give it with a dextrose. We can't mix it with it. We can't run them on the same line or anything. We can, if we have to mix it, we'll mix it with saline. We flush. We cut off the line. If it's got a dextrose, we flush, keep it cut off, flush with saline, give the medicine, and flush with saline again. And then we can let the fluid, it will precipitate. So, in IMs, I think they can cause abscesses, and I've always heard that it just does not work IM. I'm not sure why, but it can cause abscesses. So we give it PO, we give it IV. Okay, let's see. We don't give it with the milk or calcium, antacids, Milkamag, that kind of thing. So, because calcium impairs the absorption. So, and we also don't want to give it to patients on Coumadin. Now, sometimes there are reasons we might, but as a general rule, we do not give it with Coumadin. It affects the metabolism. We will hold tube feedings an hour before and an hour or two even after we give PO or down the tube feeding. So that can have to really watch for that. Some teaching we're going to do on patients with Dilantin. You'll remember they can get gingival hyperplasia, so we want them to have good oral care. We want to make sure that they don't have a rash or sore throat. We need to notify their caregiver. They might even want to use a medic alert. And if we withdraw it rapidly, they can have seizures, so that's not a good thing. And we also need to have them on a high folic acid because it can deplete their body of folic acid. Okay? Moving along. We're going to talk about status epilepticus. This is an emergency, medical emergency. It's where the patient has in continuous seizing activity. It's kind of a misnomer because they don't usually have continuous, but they'll have it so frequently that it's almost continuous. They'll have little spells of, quiet, but often, but it's just too much. It's so demanding on the body. So you can see, look at the things that it causes. Hypoxia, obviously, because remember we said when they're having that tonic phase, they aren't breathing. So you can imagine which causes hypoxia, acidosis, hypoglycemia, because you're using up all those calories. Temp's going to go up. Blood pressure's going to go down. You can have cardiac dysrhythmias. Muscle breakdown, which can eventually lead to renal failure, all that breakdown. So brain damage and death, those are pretty serious complications in my book. So if they start lasting longer than 5 minutes, or if they're repeated like every 30 minutes, then we're going to try to look into solving that, giving them some IV pushes or drug therapies and things, because we really don't want them to be having all these convulsions. The most common cause of status epilepticus is with sudden withdrawal of an anticonvulsant drug. So also other things that can cause it are infections, acute alcohol withdrawal, head traumas, cerebral trauma, head trauma, same difference there, and metabolic disturbances. Okay. We're still looking at some of the drugs. Another one, phenobarb, therapeutic range is 10 to 40 micrograms. And you can see what they can get a little drowsiness and a headache. Again, abrupt withdrawal will cause seizures. So use caution for these patients and teach them, they probably will be able to drive and all. But I think once you've had seizures and if they've just been you have to get tested and you have to have doctor's excuse and be on meds for like 6 months or something before you can drive. So, they need to be careful if the patient's just starting on phenobarb and all, working with heavy machinery and driving, those kind of things. Don't want to use it with alcohol because it is a CNS depressant. Don't want to use other barbiturates with it. They need to wear an ID bracelet or of some type. And again, we don't give it with the calciums and that kind of thing either. Give it deep IM. This one can be given IM, but deep IM. And if given IV, it's rare, but it can cause anticonvulsive action. That doesn't make sense what I've got written down here. Hold on. It's given IV rarely. That's what I meant to say. Okay, got crazy on you. Okay, so some of the interventions during a seizure, I said, was in chart 44-5. And certainly we want to maintain an airway, but that does not mean that we're going to be trying to stick in a padded tongue blade or anything. If they're having all these seizures, we're probably going to want to get an IV access, so that we can give them some medications. Monitoring their labs, their drug levels, their electrolytes, their cardiac rhythm, because we know they're going to be a setup for having cardiac dysrhythmia. And they might hurt themselves as well, and certainly we want to do some teaching for them. We want them to turn them to their side because we can help with the drainage, keep their tongue from occluding their airway by doing that. We want to teach them not to skip their doses of meds. We want to loosen clothing around them. Oxygen, as we can put it on them with a mask. Suction is needed. The bed in the lowest position with the wheels locked, side rails up, padded rails if we need them. If they're standing, of course, we want to get them to the ground, so that they don't hurt themselves falling. Protect the head from injury. Woo! Remove potentially harmful furniture or anything. And we want to teach these patients, want to stress to them that they should not smoke in bed, or smoke alone in bed. I guess they should, if they had somebody with them, because they could have a seizure and set the bed on fire or the house or kill themselves or something. They need to avoid the alcohol. And don't lock the doors in the bathroom, that kind of thing. And avoid excessive caffeine. Those are all good things. Okay, moving right along.